The cervical plexus, the brachial plexus, and the lumbar plexus are arguably three of the most intricate portions of anatomy facing any medical student. The brachial plexus is always represented on board exams. With this knowledge beforehand, you can anticipate those clinically relevant questions about the brachial plexus. Here, we'll take a look at all three of the plexuses. Yes, it's plexuses and not plexi, and try to simplify the anatomy by a marriage of the structure and functions of these nerves. The presentation is broken up into four parts. Part A, the cervical plexus and its radiculopathies. Part B, the brachial plexus and its plexopathies. Part C, the lumbosacral plexus and its plexopathies. And finally, Part D, images for you to label and practice on to help reinforce the anatomy of these areas. I strongly urge you to use the Ackland videos in your study and observation of these plexuses in a cadaver. You'll find his dissections to be exemplary. I'll show you how to find and use them in just a bit. The internet is loaded with information on how to study and learn the plexuses of the upper and lower extremities. I'll do my best to simplify it for you, and I'll point out some especially good methods of drawing the brachial plexus, which is the bane of every medical student's existence. But by the time you've completed this presentation, hopefully you'll be able to, number one, name the roots, trunks, divisions, cords, and branches of the brachial plexus. Name and identify the small peripheral branches of the brachial plexus. Describe the clinical significance of the main branches of the brachial plexus and relate them to the innervation of the arm, both the motor and sensory functions. Describe the various brachial plexopathies, cervical radiculopathies, and lumbosacral plexopathies, how they occur, present, and how they're treated. And finally, recognize the brachial plexus on ultrasound images. And if that wasn't enough, you should be able to describe the differences between a radiculopathy and a plexopathy. In addition, you'll be able to demonstrate the difference between a spondylosis and a spondylolisthesis via radiographs. After you've learned the gross anatomy and the functions of the nerves of the various plexuses, you should be able to discuss the diagnoses and imaging options for a cervical radiculopathy, a brachial plexopathy, and a lumbosacral plexopathy. Further, to help in the diagnosis of these various disorders, you learn what the Sperling maneuver is and why it's important. Along the same lines, you'll be able to describe the etiology and prognosis of a stinger or a burner injury. There's a lot here, so let's get started. Let's carry on with some more learning objectives. These learning objectives apply to all four parts of this presentation, not just this part one on cervical radiculopathies. For example, it's nice if you can draw, label, and describe the gross anatomy of a spinal nerve. We'll review that anatomy in this presentation. Then define some of the following terms. You've had these before, so this is a good review. The dorsal root ganglion, dorsal ramus, a ventral ramus, an axon, an afferent or efferent axon or nerve, gray rami communicans, a white rami communicans, a splanchnic nerve, and a ganglion. In addition, define the gross anatomy of the phrenic nerve and tell me what nerve roots it's derived from and what its function is. What is the ansa cervicalis? What structures does it innervate? Define the punctum nervosum. Demonstrate where Erb's point is. And then what is the significance of Erb's point? What is the scalenus anticus syndrome? And finally, give examples of compressive and non-compressive radiculopathies. Continuing with the learning objectives, you'll be able to demonstrate knowledge of how to read and interpret plain x-rays of the cervical spine. In addition, locate C1 through C7 and localize the axis and the odontoid process. What is the gold standard for making the diagnosis of cervical radiculopathy, specifically the foraminal compression? What two nerves can be injured performing a radical mastectomy? What are their functions? Where do they come off the brachial plexus? Explain why the thoracodorsal nerve is also known as the, quote, middle subscapular nerve. Draw, label, and explain the various portions of the brachial plexus and their terminal branches. In addition, identify the landmarks for performing an axillary nerve block, a supraclavicular nerve block, and a block near the punctum nervosum. And define the relationship of the brachial plexus to the scalene muscles. And then finally, describe what is a cervical rib, and by what two mechanisms can a cervical rib cause thoracic outlet syndrome. In addition, you'll need to define a thoracic outlet syndrome, how it occurs and what the clinical findings are. Define scalene syndrome, define a cervical rib syndrome, and of course, define costoclavicular syndrome. Define hyperabduction syndrome, and what is backpack paralysis and what nerves are involved in backpack paralysis. Define the risk factors for a brachial plexus palsy. What is Erb's palsy and what is Erb's palsy plus? What is Horner syndrome? What is a brachial plexus neuropathy? What is hereditary neuralgic amyotrophy? And what are some of the features of this autosomal dominant disease? What is a fasciculation and what is a paresthesia? What plexus is most often involved in diabetic-related plexopathies? What is medial brachial facial compartment syndrome? How is it caused and what nerves are most affected? Define the nerve roots of the lumbar plexus. What are the nerve roots of the femoral nerve and the origins of the obturator nerve? What defines the sciatic nerve and what is piriformis syndrome? And finally, what is cauda equina syndrome? What is the Patrick's test? What's the straight leg test? And what diseases are being screened for by these two physical exam techniques? And finally, recognize the many causes of a lumbosacral plexopathy. What is a radiation plexopathy? What is myokymia? What is a peripartum plexopathy and what are the findings most associated with this plexopathy? And list some of the infectious agents responsible for a lumbosacral plexopathy. What inflammatory diseases can contribute to a plexopathy of the lumbosacral plexus? What is Sjögren's syndrome? What is sarcoidosis? And how do these diseases cause a plexopathy? The scheme for the discussion of cervical plexus, brachial plexus, and lumbosacral plexopathies is the numbness and tingling scheme. Nerve root plexopathies are considered hyporeflexic, part of the peripheral nervous system, and are mentioned in box E of the scheme. Single nerve irritation, i.e. a mononeuropathy, and multiple peripheral nerves being affected by numbness and tingling are categorized under the polyneuropathy branch of the scheme. Okay, here's the learning objective that goes along with this slide. Draw, label, and describe the gross anatomy of a spinal nerve. Define the following terms: the dorsal root ganglion, dorsal ramus, ventral ramus, axon, afferent, efferent, gray rami communicans, white rami communicans, and a splanchnic nerve and ganglion. So let's review the anatomy of a spinal nerve. First, there's a sensory input. Say the right hand is placed accidentally on a hot stove. The afferent signal travels via a peripheral nerve until it meets up with a spinal nerve containing both afferent and efferent nerve fibers. However, the afferent fibers travel now selectively in the dorsal root ganglion. Ganglion means a collection of nerve cell bodies. Again, these afferent fibers travel now selectively in the dorsal root ganglion before this input enters the posterior or the dorsal horn of the spinal cord. Here it synapses and leaves as a motor functioning nerve which travels out of the anterior, i.e. the ventral horn of the spinal cord, again through a spinal nerve out to the muscle. Remember, the spinal nerve has both motor and sensory fibers. Does this make sense? This is a more complicated view of a spinal nerve. In this image, the splanchnic nerve, the sympathetic ganglion, the prevertebral ganglion, the spinal ganglion, and the gray and white rami communicans are introduced. Take a second to study this image carefully and read the associated description. Make sure you understand this before you move forward. Neuroanatomy is inherently difficult because it's somewhat obtuse and nebulous. It's difficult to really show the various neurological tracts of nerves, and the names of the structures often are like learning a new language. I strongly suggest for your entire neuroanatomy course, not just this presentation on the plexuses, but that you review all of Dr. Ackland's videos and all he has to offer in those videos. If you click here, it takes you to a YouTube video I've posted showing you how to find these videos on the school's Learning Resource Center. Please take a minute, watch the video, and make sure you have good access to Dr. Ackland's videos. The cervical plexus is formed from the ventral rami of C1 to C4, and we'll get into the details in just a few slides. The brachial plexus extends from the ventral rami of C5 to T1, and we'll take a closer look at the cervical plexus. Cervical nerve roots exit through the inner vertebral foramen above the corresponding vertebral body. Hence, there are 7 cervical vertebrae, but there are 8 cervical nerve roots. The C8 nerve root exits through the C7-T1 intervertebral foramen. The cervical plexus is composed of the ventral, i.e. the anterior rami, of the first 4 cervical spinal nerves, C1 through C4. The anterior, i.e. the ventral rami, of C2 through C4 emerge from the posterior border of the sternocleidomastoid muscle. Okay, let's think about this complex sentence for a bit. The cervical plexus is made up of ventral rami, both sensory and motor, except C1, which is motor only, of C1 and C4. The cervical plexus is made up of ventral rami of C1 through C4. The anterior ventral rami, C2 through C4, emerge behind the border of the sternocleidomastoid muscle. Sit tight. Stare at this for a few minutes. It'll make a little more sense in a few slides. But here's the take-home message. The cervical plexus is made up of ventral anterior rami, sensory motor, of C1 to C4. The phrenic nerve, which supplies the motor and sensory innervation of the diaphragm, is made up of the anterior, the ventral roots of C3, 4, 5. Remember the mnemonic C3, C4, C5, keep the diaphragm alive. The 12th cranial nerve, the hypoglossal nerve, exits superior to C1. As its name implies, it innervates the muscles under the tongue. It's a motor nerve, as is C1. The 11th cranial nerve, i.e. the spinal accessory nerve, which innervates the trapezius and sternocleidomastoid muscles, is also a motor nerve. The ansa cervicalis, ansa means loop or handle, the ansa cervicalis is found superficial to the internal jugular vein within the carotid triangle. It innervates most of the infrahyoid muscles, except the thyrohyoid muscle, which is innervated by cervical spinal nerve 1 via the hypoglossal nerve. The stylohyoid muscle is innervated by the facial nerve, C7. Here we can see the ansa cervicalis and its superior root, descending hypoglossus, and the inferior root, descending cervicalis. Essentially, the loop is made up of fibers from the hypoglossal nerve, and the cervical portion, as the name suggests, is derived from the cervical ventral rami. The lingual nerve is a branch of the mandibular division of the trigeminal nerve, that's cranial nerve 3, that supplies sensory innervation to the tongue. It also carries fibers from the facial nerve, cranial nerve 7, which returns taste information from the anterior 2/3 of the tongue via the chorda tympani, a small branch of the facial nerve which can be seen behind the eardrum. Interestingly, the most common cause of lingual nerve injuries is third molar or wisdom teeth surgery. It's pretty rare though, 1 in 14,000 according to Wikipedia. So here's the take-home message is this. The loop of the ansa cervicalis is made up of fibers of the hypoglossal nerve and the cervical plexus nerve C1 to C4. The plexus can be damaged by any operation posterior to the sternocleidomastoid muscle in the posterior triangle of the neck. It is in this area where the surgeon must be cognizant of the spinal accessory nerve, that's cranial nerve number 11, which can cause damage to the sternocleidomastoid muscle and or the trapezius muscle. Here we can see the neck view of this important area after the sternocleidomastoid muscle is retracted. Perhaps the most important structures are the jugular vein, the carotid artery, the carotid body, the ansa cervicalis, anterior to the jugular vein. The spinal accessory nerve, cranial nerve 11, is prone to injury in this area when elective lymph node dissections are done for patients that suffer from a head and neck malignancy. We can again see the hypoglossal nerve, cranial nerve 12, to the muscles under the tongue. Incidentally, what is the function of the carotid body? This small chemoreceptor is sensitive to oxygen tension, pH, temperature, and manipulation can cause bradycardia and hypotension. During carotid surgery, the surgeon will use a local anesthetic to numb the carotid body because without doing so, the patient may become bradycardic or hypotensive. There are some interesting causes to injury of the spinal accessory nerve. Some are listed below. The spinal accessory nerve injury can be either idiopathic or may have one of the following etiologies. And here are some iatrogenic causes. Lymph node biopsy in the posterior triangle of the neck, which is a frequent iatrogenic cause of spinal accessory nerve trauma. Radical neck dissection, which by definition involves the resection of the spinal accessory nerve for complete tumor clearance. Of course, we've spoken about neck surgery, excision of benign tumor masses, other types of neck dissection, such as a modified or a selective neck dissection, parotidectomy, carotid vessel surgery, i.e. a carotid endarterectomy. If you don't know what that is, go ahead and Google it and look at a picture of it. Internal jugular vein manipulation, such as vein cannulation, during placement of a central venous line. A central venous line is a large catheter which goes into the jugular vein, often placed because patients have poor peripheral IV access. It can be injured during a facelift. It can be traumatic. We can also see a result of penetrating injury, for example, being cut by glass or a gunshot injury. Sometimes a sports-induced injury to the spinal accessory nerve can be caused by external pressure, a blow from a hockey stick or wrestling, a knot in a sling, a noose during an unsuccessful hanging. And of course, a superficial love bite to the neck, vigorous movement of the neck from neck cracking, severe dislocations of the acromioclavicular joint, whiplash injuries, and so forth. Take a minute and look at the slide comments for a list of all the different injuries and types of injuries that can occur in this area of the neck. It turns out the posterior border of the sternocleidomastoid has some important anatomical landmarks for dermatological surgeons. Operating on the posterior triangle of the neck is unusual except for the removal of lymph nodes or a skin lesion. But if one of those lesions extends deeper than the superficial fascia of the neck, say below the platysma muscle, you're in danger of damaging the spinal accessory nerve, cranial nerve 11, or even cranial nerve 12 that supplies motor function to the sternocleidomastoid muscle and the trapezius muscle. Damage could cause shoulder syndrome. I've attached a paper for you to look through. I even pre-read it and marked the important parts. The area where the ventral rami of C2, C3, and C4 emerge from posterior to the sternocleidomastoid muscle is called the punctum nervosum. And technically, an anesthetic injected here could provide local anesthesia for the superficial skin overlying the sternocleidomastoid muscle, as well as potentially the lower aspect of the skin behind the ear down towards the shoulder. In theory, it sounds good. In reality, I've never seen an anesthesiologist do this. But the real damage a surgeon faces in the posterior triangle is damage to the spinal accessory nerve, and the attached paper makes one thing clear. Nobody is 100% sure how to localize and find this nerve to prevent injury. In fact, the best way of finding the nerve and avoiding it is to look for it during the operation, and once you've found it, don't mess with it. Using the landmarks described in the associated paper, I've placed 3 semi-parallel lines to try to draft out a triangle where the spinal accessory nerve would most likely be found. Some papers confuse the punctum nervosum with Erb's point. According to the paper and the diagrams in that paper, punctum nervosum and nerve's point are 2 completely separate areas in the neck. Just for fun, I put a video link here to Mr. Spock's nerve pinch that he would use to quickly make people go unconscious. Of course, that's television and that's not reality, but it looks to me like Mr. Spock has actually found Erb's point. A theoretical point called Erb's point is where the union of C5 and C6 nerve roots converge, the upper portion of the brachial plexus. Injury to Erb's point is believed to lead to a palsy. Symptoms include paralysis of the biceps, brachialis, and coracobrachialis via the musculocutaneous nerve, the brachioradialis via the radial nerve, and the deltoid via the axillary nerve can also be involved. Typically, the injury causes the person's arm on the affected side to hang at the side with the hand rotated medially, like a waiter waiting for a tip. This is called Erb's palsy. Now that we've beat the clinical usefulness of the posterior triangle to death, let's take a look at the brachial plexus. Just because I never ran into anybody needing an elective lymph node dissection of the posterior triangle or had to anesthetize the punctum nervosum, or at least no anesthesiologist ever offered, doesn't mean you may not encounter it. Sorry, it seems kind of important. Double-click on this icon to download the relevant clinical information on cervical radiculopathies. While this is only recommended reading, most of the contents of this presentation come directly from this up-to-date articles. Now let's begin our discussion of the radiculopathies commonly seen as a result of irritation to the cervical plexus and the cervical nerves. Interestingly, it wasn't until the 1940s that disc herniation and spondylosis was recognized as a cause of neck and arm pain. Spondylosis is a generic term used to describe the degeneration of the spinal column, most often degenerative disc disease and spinal osteoarthritis. It's a non-specific term. Don't get it confused with spondylolisthesis. That's where one vertebra slides forward over the vertebra below it. It's unclear whether scalenus anticus syndrome is real. A hypertrophied anterior scalene muscle could, in theory, compress some of the roots of the brachial plexus and cause irritation of the nerve roots. It was treated by resection of the anterior scalene muscle. I've never seen a case, and I know of no patient who has had his or her anterior scalene muscle resected. Perhaps the most important notes on this slide are the fact that rotational movements of the head that elicit pain, irritation, or paresthesias are most commonly a result of degenerative disease of the upper cervical spine. Flexion extension movements of the head, which reproduces paresthesias, pain, or irritation, are most commonly of the lower cervical spine. Most of the degenerative joint disease occurs in the lower cervical spine. Here we see an example of spondylosis, degenerative joint disease of the lower cervical spine. The first 2 images demonstrate the anterior lipping of the vertebra that's affected by the spondylosis. The other 2 images show spondylolisthesis, where the vertebra slip forward over the vertebra below it. The last image reveals the various grades of spondylolisthesis, not for you to memorize, but to demonstrate how significant this slippage can be. A radiculopathy affects the nerve root, whereas a plexopathy affects the nerves of the plexus distal to the root. The image here shows a ruptured cervical disc compressing on the outer, i.e. the more circumferential nerves of the spinal cord, causing a radiculopathy. This cervical spondylosis is fairly common. Other conditions can cause a radiculopathy. It isn't always due to a ruptured disc. Sometimes the herpes zoster virus can cause a radiculopathy or a peripheral neuropathy, as can trauma to the nerve root and disease causing demyelination of nerves. A disease like multiple sclerosis, or as a side effect of some pesticides, organophosphates, can cause a neuropathy/radiculopathy. Okay, let's take a second and look at some of the causes of a cervical radiculopathy. Here are 3 causes of a cervical radiculopathy. Number 1, herniation of the disc, i.e. the nucleus pulposus, through the annulus fibrosus. This usually occurs posterior laterally, affecting the nerve root. An osteophyte at the same location can reproduce the conditions too. And the third way is compression on the posterior longitudinal ligament, either by a weak ligament or by rupture of the nucleus pulposus, directly inferiorly and posteriorly through a weakened annulus fibrosis as a result of age, trauma, strain, or otherwise. In the comments section for this slide, I've placed a link which shows some severe cervical canal stenosis. Here, as the spinal cord canal decreases in size as a result of osteophyte formation, usually from old age, or disc protrusion, the narrowing becomes significant enough to cause a radiculopathy. Here, the MRI scan on the right demonstrates 2 areas of posteriorly herniated disc. Interestingly, while easy to see on this image, not all disc herniations cause radicular pain. In fact, in a normal MRI of the spine, you're likely to see several areas of apparent disc herniation, and the patient has no associated symptoms at that nerve level. The slide on the left shows various types of spinal stenosis, how some can be caused by osteophyte formation and others being congenital. If you look at the size of the canal in the top view versus the size of the spinal canal in the bottom view, you can see how compression occurs as a result of postural or osteophyte changes. Here, several examples of non-compressive radiculopathies are noted. Diabetes is one of the most common. Autoimmune diseases, I hope by now you know what an autoimmune disease is, such as histiocytosis X and sarcoidosis, can cause symptomatic radiculopathies. If you don't know what these autoimmune diseases are, Google them, but don't go down the rabbit hole that Google will take you. At this early stage in your career, you won't know what many of these diseases are. They seem like a list of names, but use this opportunity to look up a couple of these and see how nerves can be affected by the disease. Cervical spine imaging is usually normal in a non-compressive radiculopathy, usually abnormal in a compressive radiculopathy. C7, most frequently affected nerve root. 70% of patients with a cervical radiculopathy complain of pain in the distribution of the C7 nerve root, and C6 has about 20% involvement. Paresthesias, i.e. numbness in a root distribution, occurs in 80% of affected patients, but may not be localizing. Given that C7 is the most frequently affected nerve root of a cervical radiculopathy, it's interesting to note that the numbness and paresthesias may not allow for accurate localization of the involved nerve root, and hence we require imaging with either plain films or MRI. The next slide that follows will demonstrate the Sperling maneuver. In this test, if pain is reproduced, along with the paresthesia, it would be considered a positive test. C-spine pain alone is not enough to clarify the test as positive. Performing this exam on anybody you suspect has an unstable spine from, say, cancer or rheumatoid arthritis can be tricky. The last thing you need to do is to mistakenly paralyze your patient. Please search Sperling maneuver on YouTube to get a rough idea of how the exam is actually performed. Take a second and look up Sperling maneuver on YouTube to see how it's actually performed. Here we see the physician trying to detect a cervical radiculopathy. Several positions of the head may be tested in order to provoke this nerve irritation. The maneuver is first performed with the head held in a neutral position. The examiner then can press down or tap on the top of the head, and if this fails to produce the patient's pain, the procedure is repeated with the head rotated first to the unaffected side and then to the affected side and subsequently hyperextended to try to reproduce the pain and the associated paresthesia. Otherwise, it won't be considered a positive test if we just elicit the pain. I know how difficult it is as a first-year student to try to interpret radiographs this early in your career. The image on the right is a normal C-spine series. The image on the left, well, you can read the description. But in order to clarify a normal C-spine series, you must see all 7 cervical vertebrae. No exceptions to this. You must see all 7 cervical vertebrae clearly. If they're not seen clearly, the patient either needs repeat testing in the X-ray department or a CT scan of the affected cervical vertebra. Once you suspect that your patient is suffering a radiculopathy from the cervical spine, manually pulling and elevating traction upwards and with relief of the pain and decrease in the radicular symptoms, as you see in the image on the left, is a good test for cervical radiculopathy. These symptoms can often be improved by having manual traction placed in a vertical direction on the cervical spine. The manual traction done on the young lady here on the right is being performed by lifting her head against the weight of a bag of water. This is a common treatment for mild radicular pain from cervical disc disease. In my experience, manual disc distraction performed with the examiner's hands, as you see on the left, rarely results in the patient being relieved of their symptoms because they're so distracted by the examiner's hands, they lose focus of their symptoms. If it can be done properly by a qualified physical therapist, the manual neck distraction test is still a good test. There is little doubt that if the initial plain radiographs do not show the etiology clearly of a patient's cervical radicular symptoms, an MRI would likely be the next step. While the gold standard for foraminal compression would be CT myelography, I suspect that would still be the last test because it's the most invasive. Again, the gold standard for foraminal compression would be a CT myelogram. Here, we learn that when an EMG, an electromyelogram, is performed, i.e. a nerve conduction test, that such studies alone are not sensitive for diagnosing the radiculopathy because sensory nerve action potentials are normal when the lesion is proximal to the dorsal root ganglion, as it is in radiculopathies. Go back and look at the anatomy of the spinal nerve so this makes sense to you. Risk of CT myelography include bleeding, infection, headache, CSF leaks, accidental injury to the spinal cord, and as such, performing this gold standard exam should be preceded by the other imaging modalities to potentially decrease the diagnostic risk. This completes part 1 of our introduction to understanding the anatomy and the clinical ramifications of radiculopathies and plexopathies. Next up, we'll look at plexopathies of the brachial plexus.